Our first speaker this morning is Dr. Joan Merrill. Joan is chair of Clinical Pharmacology Research Program and a member of the Oklahoma Medical Research Foundation, professor of medicine and adjunct professor, School of Pharmacy at the University of Oklahoma. She received her bachelor's degree at Vassar, her medical degree at Cornell. She was an intern and resident at St. Luke's and Roosevelt, and a fellow in rheumatology at NYU. She then was a research fellow at Columbia. She's medical director of the Lupus Foundation of America. She's co-chair of the American College of Rheumatology Lupus Study Group. She's the funding chair of the International Congress on SLE, which is in Vancouver. Pam and I are going to this meeting. I don't know if anybody else is going, but it should be. We've been to the couple of lupus congresses. They're very good. She's also the lupus section editor of Current Rheumatology Reports and the Medical Advisory Board for Lupus Now. She has numerous publications, and she's going to talk this morning about options in the management of mild, moderate, and severe lupus. Joan.
I was very impressed listening to my credentials. I wondered if I should admit to you all that I almost was a little late because I got locked in the toilet. And so I'm going to talk a little bit about some of the options that we have in the management of mild, moderate, severe lupus. I wish I could tell you what the standard of care is. Obviously, I can't. And so I'm hoping that as a group of people here, we might be able to approximate that with a little hand raising as time goes on. My disclosures are a number of pharmaceutical companies for which I have consulted and worked in clinical trials and received funding for research. You can see their names right there. If I could see, I would list them to you. I'm going to be talking about off-label treatments today, which is no surprise to rheumatologists who recognize that there are very few on-label treatments for lupus. But the exceptions are prednisone, prednisolone, hydroxychloroquine, and aspirin, which were approved more than 50 years ago. You know, we always used to vaguely say almost 50 years ago, and someone at the Lupus Foundation of America looked it up, and it turns out that the 50-year mark since a new drug was approved for lupus was November 22nd, 2008. If you had a patient in your office with moderately severe discoid rash, including some weeping and burning lesions, who was quite distressed about it, plus moderately severe inflammatory arthritis, and this patient had already been treated with hydroxychloroquine, and I'll raise the ante, maybe you even added quinacrine to that at some point, and you tried some low-dose steroids. She's still on those. You haven't gotten her off the prednisone. And you also gave her 2 bump-ups, 2 IM injections of depomedrol, 160 milligrams IM. What would you do now? So what is the standard of care? I'm going to ask you to help me figure that out. How many people here at this point would immediately give this patient, who is in some distress, some more steroids? Wow, I would. How about, see, I put it orange. That was the right answer. No, actually, no, I put it orange because that's the only approved treatment. So we have only one person besides me who raised their hands that they would immediately now give the approved treatment. I think we have just demonstrated that the standard of care for lupus is use of off-label medications. How many people would go to azathioprine here? 1? I would. I think people aren't voting here. That's what I think. You have to vote. What, you want me to talk about standard of care when it is us who know it? I really do think that's right. I think probably we have a quorum here to get a very good sampling of what standard of care in the United States is, so please join in. Okay, so let's go back. How many people would give more steroids? Good. Better. How many people would also give azathioprine or give azathioprine? Okay. How many people would prefer to give methotrexate? Good, a lot. Okay. How many people would give mycophenolate? Nobody goes there first, but you know it's off-label now. Yes, I know it causes diarrhea, but it's off-label now. Leflunomide, how many people would use leflunomide? Okay. How many people would immediately go to rituximab now? Abatacept or abatacept, whichever how you pronounce it. Cyclosporin, TNF inhibitor, plasma exchange, thalidomide. Nobody's going to go, oh, thalidomide, all right. He likes to treat discoid with thalidomide. Okay, I guess you figured out how to fill out all those forms from Celgene, right? He has somebody in his office who knows how to fill out the forms from Celgene. All right, so basically, the standard of care is really up at the top there. We can see that. And there are some tried and true drugs that empirically we've been using for years. They are more or less effective in some subset of our patients. How many people are satisfied that with your first choice, you are going to be able to really make 100% of these patients better? 80%, 60%. Okay, thalidomide, 60%, and steroids plus, what was it, azathioprine? Methotrexate, steroids plus methotrexate. Pretty aggressive treatments, by the way, but okay, 60%. How about 50%? All right, a few more hands are going up. 40%. Okay, good. So basically, I don't think we're satisfied with our standard of care. Now, one more set of questions for everybody. How many people have ever used azathioprine in lupus? How many people have ever used methotrexate? Mycophenolate, leflunomide, rituximab, abatacept, cyclosporin, TNF inhibitor. So some people have begun to use TNF inhibitors in lupus. Plasma exchange. Those are the people who go to the hospital and see the sick patients. Thalidomide, we have at least one. We have a few. Okay, very good. So I think that that is probably our best approximation to what people are doing. And you know, I recycle these slides, and I go around in a lot of places, and it's about the same right now wherever we are. A lot of people have used rituximab, and not very many people have used abatacept. They're both on the market. They're both off-label, just like all of our other drugs. And I mean, I'm going to speculate that the reason for that may be that there is an incredibly long list of papers, all of which are anecdotal, and there's some small case series, suggesting that rituximab may work for hematologic lupus. So I think that's how it happened. There aren't too many papers about abatacept and lupus, except for the one reporting a clinical trial that did not meet any of its primary and secondary outcomes. But on the other hand, a clinical trial of rituximab in lupus also did not meet any of its primary and secondary outcomes. And so we're used to treating empirically based on experience, and that is the standard of care for lupus. I don't think any of us are happy about it, but that's how it is. So we can also get at standard of care by looking at what people were doing when they were entering patients into clinical trials. This is data just from what people had been taking before they were entered into the phase 2 multi-center study of rituximab and SLE. And right now we can look at the data from both the placebo group and the rituximab treated group, because at this point nobody's been treated yet. So these are just people walking into the office with enough active disease while they are on the following background medicines. And you can see that the 3 most commonly used medicines were mycophenolate, methotrexate, and azathioprine. I don't think that's a surprise. What might be a surprise to you is that it was about 30-30-30, which we didn't really find here in this group when we're thinking about first-line treatment. And that's a clue, I think. I think it's a clue that these may have been somewhat more ill patients than our average lupus patient in our hospital. And that's good, because that's what that clinical trial design was looking for.